All right, everybody, I think we're going to go ahead and get started. Thank you for joining this month's Grand Rounds presentation. Today, we will be hearing from Dr. Khan. He's going to tell us a little bit about complex regional pain syndrome. So without further ado, here's Dr. Khan.
We're going to talk about complex regional pain syndrome. So a little background about complex regional pain syndrome. During the Civil War, when and even before that, the soldiers and the civilian population were coming into the clinics of the surgeons, and they actually were having low velocity, high mass injuries, and they had large, unproportionately severe pain with these injuries. It was the term was coined as causalgia initially in the beginning of the century, and by 1940, it was actually switched to reflex sympathetic dystrophy. And at that point in time, in early part of the 20th century, it was thought that it is because of the abnormal efferent reflexes from the sympathetic system to the bodily injury, to the trauma, these unusual type of pain syndromes are happening. Pathophysiology was not very clear, and the diagnosis was not very commonly made, except in the specialty clinics and the orthopedic clinics. Now it is more widely diagnosed because, and we will see it in short, that now there is a diagnosis criteria, which is used very stringently from the International Association of Study of Pain. So now it is being diagnosed much more. And other reason for more frequent diagnosis, in addition to standardization of the diagnostic criteria, that the discovery by the personal injury lawyers who actually make each and everything look complex regional pain syndrome. So if it sounds like a duck, quack like a duck, walk like a duck, then it must be the CRPS duck. And then additionally, new treatments are coming. It is a favorite topic for the pain physicians to discuss during the pain meetings, and research has been done and new treatments are out there. So that's another reason that it is more frequently recognized among the pain specialists. And patients actually, when they are going and searching for the answers on Dr. Google, they are able to find this, and they come to the clinic and they say, I have CRPS. So these are a few reasons where you can see that the term is easily, you can actually hear the term quite more often. How does it present initially in the clinic? It's often seen after injury to the limb or related to some inciting event. There are, most of the time, there is some cause or some index event which leads to this type of pain. There are few examples where it just starts without any rhyme or reason, but those are very far few in between. It present with the skin color changes, temperature changes, changes in the appearance of the limb or the body part. Pain is often, as I mentioned earlier, disproportionately very severe, excruciating. If you compare with the intensity of the injury, it is excruciating pain, uh, burning pain, tingling, electric shock-like pain, and as I mentioned, out of proportion to the stimulus or the event. That's how they present. The motor effects where they have dysmotility, an abnormal posture of their limbs, swelling, erythema of the entire organ, not just one single finger or one single body part. The entire limb actually gets affected. The skin changes, dryness, scaling, temperature changes, Raynaud phenomenon. Those things are very common. Uh, and pain is the most common finding. 87% of people actually present with the pain. And some of them actually just present with not the pain, but with sensory changes, where we call it touch allodynia, hyperalgesia, where the touching of the clothing, uh, blowing of the air, running of the water, all of that actually causes severe pain, intolerable level of pain. Touch, they cannot even put their foot down on the ground because the cold of the floor, cool floor, cold floor, that actually causes problem and severe shock and pain. And the vasomotor dysfunction, it means that there is asymmetrical edema. It means it's not similar on both sides, the way we see it in the heart failure or the kidney dysfunction. It's a one-sided edema in the limb, and there are temperature changes, abnormal sweating. Either they have no sweating at all and the limb is very dry, or it's excessively sweating, where they actually have to cover it with the clothing or tissue paper. So hyperhidrosis and anhidrosis is there. Their nails are brittle because they actually stop trimming the nails. So they feel that if the nails are trimmed, that will cause more shocking pain, electric shock like pain. So they stop trimming of the nails, but on top of it, their skin changes, so nails are brittle and oddly shaped, and they are usually breaking apart. They have myoclonus, so movement disorder is there. Patient may have muscle jerking, myoclonus, rigidity in affected limb, contractures of the hand and feet. One interesting thing is that, like, if you actually try to touch their affected limb, you cannot, but they are able to rub their affected limb with the other non-involved hand and foot, and they won't feel that touch related pain, or touch allodynia is not there. So patient can do it, but the examiner cannot do it, or the family member cannot do it. That's actually because of the central mechanism of this disease process, and we will talk about that in a bit. So this is the diagnostic criteria which was issued by the International Association for the Study of Pain. It was a bit cumbersome. It was more generalized. The cause was there, that there should have been an initiating event, and there should be allodynia or hyperalgesia, as we talked about it earlier, the sensory allodynia and hyperalgesia, vasomotor phenomena. And then you have to choose the one symptom from each category. So it was initial attempt to put something into the box. So it was a good starting point in 1993, and then I believe, yeah, about 10 years later, um, again, international IASP, International Association for Study of Pain, they actually came with this Budapest criteria, which is the standard of care for both research and clinical diagnosis of this CRPS. Um, this actually does not talk about um, whether this is related to the event or not, whether this has actually um, any other physiological, patient has any other physiological condition that should not be there. Nothing of that sort is there. So it's much more simpler, much more easy to perform and go through when you are talking to the patient and examining them. And uh, you can easily see the dystonia and tremor and weakness and the trophic changes. So a lot of things are mostly observable, and just jot down the criteria, and that's much easier. And that's the reason, one of the main reason that the diagnosis is frequently seen in the pain clinics. The poor prognostic risk factor means the reasons or association where if any of these things are present, there is a high risk that patient's pain will never ever go away. The top of the list is smoker. And then the rest of these are also pretty commonly associated with the poor prognosis in the CRPS patient. Pathogenesis, these are very much of a research-based possible pathogenetic mechanisms. None of them actually are definitive. People did attempt to find out the causes, but as these are available or written and listed here, it does not mean that this the pain is the result of these problems. They are found to be there. They can be the result of the pathology and just found to be there in some of the patient population of the CRPS, and they can be just the marker of the disease but not the cause of the disease. And these actually interesting because now the talk is about CRPS is not one disease, is a heterogeneous disorder, and there is a thought process where CRPS and the attempts are being made to regroup the CRPS into smaller subgroups. So as you can see, not all of these are present in every CRPS patient. So as the time progresses, we'll be able to see that, okay, some of the CRPS patient subgroup has one abnormality and others do not have abnormality, but they actually have something different. Out of these, rather than going into each and every list, into each and every enlisted point, I just want to make sure that we can see the one which is listed at the very bottom, that there is no pre-morbid personality risk. When we actually see these patients in the CRPS in the clinic, sometimes openly and sometimes in the hidden manner, all of us actually think that, oh, this patient is a CRPS patient from the personality point of view. So kind of like a whining patient, and that's why they ended up happening. They ended up getting this CRPS syndrome, and that's not true. They actually checked all type of personalities, and it was found out that there's no personality risk associated with this diagnosis. Um, so CRPS 1 actually is called, or have been called, reflex sympathetic dystrophy. There is no injury to the nerve which can be identified. That's how the current division is. It might end up changing in the future, but currently, if you cannot identify one or two specific nerves, and it's just like, yes, I had some type of injury, and now I have CRPS, that's called CRPS 1, or RSD. When you have the um, definitively injured nerve. So for example, after amputation or after severance of the sciatic nerve or any other nerve where you know that patient did have certain injury to a specific nerve, that's called, and then they develop symptoms, that's called CRPS2 or causalgia. Um, and usually it follows the distribution of the nerve, but otherwise it does not necessarily have to follow the distribution of the nerve. It is mostly diffuse involvement um, in multiple dermatomes and myotomes and sclerotomes uh, associated with this nerve. Um, Sometimes the CRPS start in one limb and then it actually start involving across the body on the other side of the body into the other limb in the same fashion the way it started in the first limb. Um, so CRPS, yeah, that's how it is actually subdivided currently. Testing wise, no specific test is available. When these tests are being done, those are actually to rule out other differentials or see the stage of the CRPS, for example, in the bone scan or in the X-rays, to decide whether it's a chronic or the early onset, and thermography to just detect the blood flow changes. But none of them are specific. They are so none of them are the gold standard diagnostic test for the CRPS. The gold standard for the diagnosis is currently, as of now, Budapest criteria, as I mentioned earlier. The treatment actually consists of some of these things which are given here on this list, and those actually are patient specific, as we will see in the following slides. So not all these things actually help all the patients. Some of them actually get better with something and others don't. That's how it goes. But there's a long list. I just chose some of those. If you want to add magnetic stimulation of the brain and the TDCS, which is direct current stimulation of the central nervous system or brain, that's also part of the treatment list. And as I said, there are few which are listed here in this list. What is functional restoration? That was mentioned earlier. Pretty much everything written here, sort of steady progression from the gentle movement, so gentle weight bearing movement. Basically, the idea, the main idea behind is to have gentle push of the limb and the patient to decrease the dystonia which we see in the patient, and indifference or fear to move the limb. And this therapy is actually to counteract that fear, to counteract that counteract that voluntary or involuntary um, fear of movement and dystonia in the involved limb. Um, so that actually leads to improvement. Similarly, not only dystonia, also when the functional restoration is um, being attempted, you also do the gradually increasing uh, intensity of different sensory stimulus to make the central nervous system get accustomed to the different level of stimulus and not result in shock type situation, which patients actually get most of the time. Psychotherapy is very, very important because with the onset of pain, chronic pain and intractable pain, when patients are not able to get the answers, um, lot of people have depression, anxiety, especially with the financial losses. Um, this happens in mostly a lot more commonly in the younger patient population. And as I mentioned earlier, the these patients have a fear. They have a fear of moving their injured body parts. So kinesiophobia is there, and negative reinforcement uh, actually stop them from achieving the full range of motion into the involved body part. Um, and as a result, they actually develop contractures, which we know that it's a huge problem. Once contractures develop, then you will be either undergoing a knife, or you will need the to release the contractures, or you will actually need to do the chiropractor manipulation under anesthesia time and again, and that even does not guarantee that those contractures will be gone forever, whether you do surgically or non-surgically. Cognitive behavioral therapy is the most beneficial among other techniques. Family therapy also has a role for the treatment. As I mentioned, pharmacotherapy is mostly trial and error based. We borrow the treatment strategies from the neuropathic pain treatment, and those techniques and those medications. None of them actually are approved in the randomized control trial. Initial drugs, as we all know, for the neuropathic pain treatment are gabapentin and pregabalin. TCAs, bisphosphonate, vitamin C, and oral steroids. All of those have been tried. Additionally, I have used Vimpat, which is lacosamide, carbamazepine or scarbazepine, oral ketamine. Low-dose naltrexone and oral ketamine has a very significant following among the pain physicians, and a lot of anecdotal data and evidence is there, which actually leads us to use oral ketamine and low-dose naltrexone, and that is very helpful for some of the patients. SSRIs and SNRIs, as we all know, opioids should be avoided, but we all see that there are tons of patients who actually are on the opioids unnecessarily for the CRPS patient. Intrathecal baclofen, IV steroid infusion, IVIG infusion, IVIG treatment, anticonvulsant infusion, IV lidocaine, IV ketamine. Where I've been trained, we actually used to use IV lidocaine and IV ketamine for these patients under the research study protocol, and we have seen great many benefits for those patients. Interventional approaches, we do the cervical and lumbar sympathetic plexus blocks, stellate ganglion blocks, sphenopaton ganglion blocks, um, rectus spinae, paravertebral blocks. So a lot of nerve blocks and bear blocks. We used to do these bear blocks when I was in the training, but outside the training, we never tried using those. A spinal cord stimulator, DRG stimulation, pumps, thermocoagulation, like using the pulse frequency uh, for the DRG as well as peripheral nerves can be also used with different level of success for these patients. Outcome, as I mentioned previously, it was believed that blocking the sympathetic nervous system will result in decrease in pain and improvement or complete treatment and cure of the CRPS. That turned out to be not true. A lot of people get substantial substantial benefit, but not all of them actually get benefit from the sympathectomy, whether pharmacological or surgical. Because if that was the case, sympathectomy would have been the choice or procedure of choice, but it is not true. Overall prognosis is poor. We used to, still have to find out that study, but I read somewhere where 1/3 of the patient actually get better on their own. 1/3 continues to have slow, progressive recurrence and remittance. Recurrence and remission of their symptoms. So off and on, they continue to have their problems and issues. And 1/3, so 1/3, 1/3, 1/3. So 1/3 actually gets better on their own in 6 months to 1 year. 1/3 actually never gets better, and the rest of the third actually continues to have some levels of problem, not necessarily severe problem, but some level of problems for the rest of their life. And for patient satisfaction, it should be a multi-pronged, multidisciplinary approach. Patient report extreme lack of satisfaction, understandably, because nobody is able to fix their problem. This last slide, I just wanted to show you guys that, the picture is from the very last reference, which I put into the next slide. The latest mechanism, and this article came out. So this picture is from the recent article. It came out about 2 months ago. And I put this picture out of that reference article, that there is a role where we actually have to think about injury and fracture to the bone, causing excessive inflammation, leading to nociceptive and nociceptor hypersensitization, and different type of molecules and neuropeptides are released, and there is a feedback circle, and that feedback circle needs to be broken, and because it leads to the osteoclast formation, and the eating up of the bone, and bone density decreases, more fractures happen, and this cycle continues. So to break this cycle, we have certain checkpoints, and one is TRPA, TRP, which is toll-like receptor protein, and CGRP. So some of those medications are present currently, although have not been tried so frequently for the complex regional pain syndrome, like the CGRP for the anti-CGRP for the migraine headaches. Those have been tried, but with variable results, have not been approved by the FDA, as well as TRPA1 capsaicin actually helps at that level and at that checkpoint. But in addition to these known medication, which may or may not be utilized, the herbal medication from Japan actually have been used, and they have been using these herbal medication called Campo or magnoflurine or Boyogito. Those actually are being used in Japan right now currently. So we actually have to think out of the box that in addition to the medication which are available or soon to be available to us, there are other possibilities for the treatment of this complex pain syndrome. But the full article can be actually looked up. It's in the reference section. That's it. If you guys have any questions, let me know. I'm going to stop sharing the screen.
All right, everybody, as usual, we are going to wrap things up with a brief Q&A session. I think to kick things off, I will shoot one at you, Dr. Khan. How long does it typically take to see a reduction in pain for patients that are experiencing this? And how long until we see like a plateau and they kind of reach their maximum potential?
Everyone is different, but usually between 3 to 6 months, we are able to actually say that, oh, this patient is progressing towards the betterment and this patient is not going to go anywhere. Because with the current definition, something becomes chronic if they continues to have pain for more than 3 months. So after 3 months, not going to get better, it will be very slow progression. It is very much, I have not seen anyone actually getting better after 3 to 6 months of worsening.
Thank you. Everyone else, I've given you the option to unmute yourself, or you can type a question in the chat. I'll read it off for you. So anyone, feel free. Any last calls for questions? Okay. Well, I guess that would conclude May's Grand Rounds presentation. Thank you, Dr. Khan. Thank you, everyone else, for attending. And I hope you have the great rest of your week and enjoy your weekend. Thank you, everybody.
Thank you.